can you briefly introduce yourself and describe your path to becoming a gastroenterologist?
Sure. Yeah, my name is Shivaprasad Marulendra. So I've been a gastroenterologist now for 29 years.
Oh, wow.
I started way back in 1996. And initially my practice was in Pennington, on 1871 Pennington Road, close to TCNJ.
Okay.
And from there I moved to Hamilton back in 1999. So I've been here since then.
Okay.
In terms of the pathway, so I was born and raised in India.
Okay.
So I also completed my medical school in India, and I came here in '88 as an immigrant. I first did my internship in New York.
Okay.
That's a 1-year internship, and from there I did a 3-year residency and chief residency in Wayne State University in Detroit. Then a 3-year fellowship in Richmond, Virginia. So from 1982 to 1996, that was my 14 years of medical school and training. So it's a long pathway. And part of it is, I think, being a foreign medical graduate, as we're called, I had to take the entrance exam. That took up a year's time. So, but here, if it's after 4 years of college, 4 years of medical school, 3 years of residency, and 3 years of fellowship. So roughly 11 years. But for local graduates, it's usually 11 years after 4 years of college. It's still a long time.
So that's for like people who are not specializing in anything?
So what happens is, once somebody completes medical school, there are two main branches: a medical division and a surgical division.
Okay.
So in medicine, there are several pathways. One is called internal medicine or categorical internal medicine, which is 3 years. So typically, people who are interested in fellowship have to get into categorical internal medicine.
Okay.
There is a pathway called primary care, which is typically called family practice.
Okay.
So doctors who choose family practice, they can do only primary care, 3 years of residency, and usually they don't go into any fellowships. And in general, they don't qualify for any fellowships either. They are taught to be just general practitioners.
Okay.
Yeah.
What does a typical day look like for you?
See, for me, I have 2 parts to my practice. I call it a hybrid practice. So here, it's usually 7 a.m. to 5:30 p.m., 5 days a week. Most gastroenterologists also take hospital calls. We typically don't, by choice. So people who take hospital calls, so they have a 7 to 5:30, and then if they have a hospital consult, they go to the hospital and go home around 9. I feel like, the quality of life would be terrible if somebody did that.
Yeah.
So by choice, we have concentrated our practice just to office and surgery center.
Okay.
But I also work 2/3 of my time here in New Jersey and 1/3 of my time in Illinois. I
nice.
work at a university hospital there. And there, my days are 14 hours per day.
Wow.
It's a very busy location. It's unfortunately, a rural, underserved area where there's a huge shortage of physicians, so that my days are much longer.
Okay. Were there any subspecialties within gastroenterology that you explored?
Yes. So we are what I call general gastroenterologists. We take care of the esophagus or food pipe, the stomach, the small intestine called duodenum, colon, also known as large intestine, pancreas, liver, and gallbladder. So we take care of the whole gamut within GI. But if somebody wanted to subspecialize within gastroenterology, one can choose only hepatology or liver diseases. Unfortunately, liver disease is extremely common worldwide, and especially so in the United States, for 2 main reasons. One, we have a whole lot of alcohol abuse going on in this world. It is kind of fashionable. leads to a little over 48,000 deaths per year in the United States, 800,000 deaths per year worldwide. So when you look at it, per year, approximately 6 million people pass away every year. Old age, cancer at a young age, motor vehicle accident, gunshot wounds. So if you look at it, out of the 6 million, about 800,000 deaths are directly attributed to alcohol.
Wow.
So typically it's alcoholic liver disease. So they have a subspecialty called hepatology that concentrates only on liver diseases.
Okay.
The second is my wife. It's called pancreaticobiliary. You may know this. Pancreatic cancer is extremely common worldwide. And unfortunately, 95% of the people who are diagnosed with that die. Only way to survive is early diagnosis. So she subspecializes in early diagnosis of pancreatic cancer. So I told you about the pathway: 4 years of medical school, 3 years internship in internal medicine, 3 years fellowship. On top of that, she has 1 additional year of fellowship. That's why she's a subspecialty.
Okay. So you kind of mentioned it before, like for these common diseases, what are the best ways to prevent them?
So for example, we spoke about liver disease, right? So alcohol is now the #1 cause, but in the United States, obesity has become an extremely common problem. So in some states, more than 50% of the population is overweight. So being overweight is a primary reason for this called fatty liver. So then fat accumulation in the liver damages liver cells, leads to cell death and scar tissue formation, which is also known as end-stage liver disease or cirrhosis.
Okay.
So minimizing alcohol intake, and if at all possible, the best way, I've always said, to not be an alcoholic is never start.
Yeah.
The one who doesn't start will never become an alcoholic. So being overweight, choosing low-calorie foods, avoiding concentrated sugars, high corn, fructose, corn syrup, things of that nature. The third is cigarette smoking is usually known to cause lung cancer and heart disease, right?
Yeah.
But cigarette smoking is also extremely common for cancer of the esophagus and cancer of the pancreas, as well as pancreatitis. Colon cancer is the most common GI cancer. Red meat intake is associated with colon cancer. Eating fruits and vegetables is associated with a decrease in the risk of colon cancer. So when it comes to lifestyle, to summarize, not drinking at all or drinking in moderation, not smoking, choosing low-calorie foods, exercise, and avoiding red meat, and eating a high-fiber diet with fruits and vegetables, they minimize a lot of GI disorders. The next is, so I told you about the deadly conditions. There is a very common condition called diverticulosis, or pockets in the colon. That can lead to infection called diverticulitis with perforation, where stool can leak into the abdominal cavity and cause a serious and a life-threatening infection, or massive bleeding with which patients can pass out. So there, an increase in fiber intake, fruits and vegetables again, so they decrease the incidence of diverticulitis. So you have deadly conditions and you have quality of life issues in terms of GI. So with quality of life, you have acid reflux and irritable bowel syndrome. Those are the two main quality of life issues. With acid reflux, cutting down on acidic foods like tomato sauce, orange juice, caffeinated drinks like coffee, soda, carbonated beverages, avoiding large meals, avoiding late night meals, they minimize the risk of acid reflux. So acid reflux in turn, in the long term, if uncontrolled, can cause ulcers in the esophagus, that can cause bleeding. It can also cause scar tissue formation with narrowing of the esophagus, where food can get stuck in the esophagus. And in general, it causes a very low quality of life.
Mm.
So avoiding those food items can increase gut health.
Okay.
And then finally, when it comes to irritable bowel syndrome, increasing fruits and vegetables there again has been shown to decrease suffering attributed to irritable bowel syndrome.
Okay. That syndrome, it doesn't have a cure, right?
Correct. With irritable bowel syndrome, there can be control of the symptoms, but there's no cure.
Okay.
Yeah.
So are there like researchers in the field that are making progress in that?
The answer is yes, but I'm not quite sure that a whole lot of progress has been made.
Okay.
For example, there's something called a low FODMAP diet. It's a very complex diet that hardly any of my patients can ever either understand or follow. It's such a stringent control of diet that most people get frustrated. You either get frustrated with the disease or the diet. And eventually, food is one of the things that we enjoy the most. And as a result of it, people say, what, okay, I'll put up with my diarrhea, but I want to eat what I want to eat. Yeah.
So I know there's like screenings for older people. Are these diseases more common in older people?
Correct. So, for example, the most common cancer in terms of GI, when we use the word screening is checking an individual for the potential of a disease before they develop symptoms. Okay. So the disease has to affect a large population. The test should be easily available. The test should be affordable, and it should make a significant difference in terms of decreasing the disease, and in this case, a deadly disease.
Okay.
So colon cancer screening is by far the most common screening test that we use. Disease happens to be more frequent in people over the age of 45, so we start at age 45.
Okay.
So that's the most common screening test that we do. There used to be a screening for acid reflux with a condition called Barrett's esophagus that puts the person at risk for a cancer of the esophagus. That's no longer a standard test unless they have symptoms. We don't do it.
So is that why they don't have like screening for the younger population?
Correct.
Okay. What are some skills you learned throughout your journey that you feel are essential for a health professional to have? So,
in terms of medicine, you've probably heard this term called the art and science of medicine, right? Science obviously is very important because without science, you can't have a way to measure outcomes. Science is what has taught us all that we know in terms of what causes the disease, what makes it worse, what are the complications, what's the treatment. Change in diet, change in lifestyle, pills, or surgery. So that is the scientific aspect of medicine. And science is bland. You just get a very sterile description of what the disease is. But as you start taking care of people, you realize obviously science is important. There's no question about it. When it comes to science, it gets drilled into you so much that it becomes second nature. See, for example, we are a procedure-driven specialty. I've done more than 50,000 procedures in my lifetime. So yes, I will have some tough ones, but in general, it's second nature for me. I hardly ever have to think about what to do, and I don't boast about it, but that's what happens when you keep doing the same stuff over and over again. But for me, the art, or humanity as I call it, is much more important, because you realize it's not just a sterile disease, it is affecting the quality of life of a human being. It is affecting their ability to get up and go to work and earn a living and take care of their family. Not being able to earn a living brings its own problems. How do I pay the bill next month, right? And how do I pay for the mortgage? How do I get food for my children? How do I get them to school? So to be human, to be humane towards your patients, for me, that is exceptionally important. So, I've been fortunate enough to teach a lot of students who want to get into medical school, medical students, residents, fellows, even people in practice. Something funny happens, okay? As I told you, I'm approaching my 30th year in practice. And a lot of young doctors were not even born when I started practice. So they kind of look at me as the old guy, right? It does give you a little bit of the command in the chain of command. So I always teach them, listen, I know how important science is, but never forget humanity. That is what will make you a really good human being, but a good physician. Because when people see that you care for them, you care about them, and that you'll go the extra mile to be able to help them, that is when I think you truly fulfill your mission as a physician.
Yeah. What are some challenges throughout your journey that you faced, and how did you overcome them?
I'd say probably for me the biggest challenge was moving from India to the United States. And things were a whole lot different back then, okay? Foreign graduates were not as accepted. And the system was not as fine-tuned as it is today. For example, even new physicians who come in, they take their exams. You have a computerized way of sending in your application. You can sit in your home and fill out the application, pay the fee, and not that it's easy, but the system is in place where internet has made it easier. So back in the day, plus what has also happened is with a large number of international graduates, there is a way for us to help or mentor newcomers and say, look, these are the steps you have to take to qualify, take the exam, and get into a residency or fellowship. Those things we were not quite the first batch, but we were relatively new as foreign graduates to the United States. So this large data bank didn't exist. There used to be something called a green book. So you had to go find out, which is a foreign medical graduate friendly institution. You had to write to them, request an application, fill out the application. Computers didn't exist. Everything was handwritten, okay? And you had to send fees for them to process the application. Most of us didn't have enough money to pay $30 for application processing. And truth be told, because eventually I became a chief resident, I sat on committees where we would screen people to get into residency. They would look at names like mine, long Shivaprasad, Marulendra, boom, it would go into the trash can. I am not joking. This country has been fantastic to me. I'm very grateful. I'm not saying anybody is a racist, but you look at John Smith, local graduate, versus Shivaprasad Marulendra. It's like, I can't even say this guy's name. I don't know if he can say his own name. So we had a lot of trouble. I had one of the highest scores on the West Coast.
Wow.
I didn't get a single secondary application from the West Coast back then. That's how I ended up moving to Northeast. So when I tell that to younger people, they go, oh my God, really? It used to be that way? Yes, I believe that. So for me, that was the biggest challenge. But once I got in, I have to say gratefully, people recognized my quality of work, and kind of climbing the ladder was pretty easy for me.
That's good.
Yeah. So people were very fair that way.
Okay, that's good. So what do you find most challenging about your job now, and what do you find the most rewarding part about your job is?
In terms of challenge, honestly, there's not a whole lot of challenge for me. Okay. And again, part of it is you do the same thing for decades, it becomes second nature. That's number one. The second is, thankfully, being in the community for a long period of time, I made a lot of friends and contacts. So in terms of being able to take care of patients, one text, one phone call from the CEO down to the chairman of medicine or head of the endoscopy unit, they hear my name, things get done. And again, I'm not boasting. That is the advantage of longevity. What was the second part?
What do you find is the most rewarding?
It's after being around for such a long time, it's the love and trust you earn from your patients and their families. Okay, so we are one of the last few private practices in the area. I have many 3-generation and 4-generation families.
Wow.
So back in 1996, I used to take care of their grandparents who have since passed. Their children who used to bring their parents, they were in their 40s, because most people become our patients in their 50s.
Okay.
So now they are in their 70s and 80s,
Wow.
and their children who are in their 40s and 50s now come looking for me, and I recognize the last name, and I ask them, and they tell me, "Yeah, you used to take care of my grandpa." And
so cool.
these were people your age back when I used to take care of their grandparents. Now they're in their 40s and 50s, and they come, they give me a hug, and so that's the most rewarding part.
That's really nice.
The money's not bad either.
Well, thank you so much for the interview.
You are most welcome.